I have worked in Nottingham as a clinical academic, consultant and researcher since 1990, and we set up the Children's Brain Tumour Research Centre in 1997 with a fundraising campaign through the University of Nottingham. And that started to bring money in, and some of the people in this room benefited from being employed in that money in their early part of their career. And Beth, you're going to hear about later, who was our first academic appointment, so it's a great celebration to see her here today. The Children's Brain Tumour Drug Delivery Consortium, which is Emma Campbell here, and I co-lead it with Ruman Rahman, was set up to promote awareness of drug delivery as a way of enhancing treatment for the future in brain tumours. And this is part of the vision of the Children's Brain Tumour Research Centres. We want to create a situation where the children who get experience brain tumours can achieve a full, healthy and independent life for every child. And we wish to do that through research and accelerate progress. And so that's our mission. And that picture there is of the Vice-Chancellor of the university in 2014 and the children for whom we cycled the country for 1,400 miles to raise £2.2 million in that year for brain tumour research. So we had very, very substantial backing from the university leadership for this programme. These photographs are for the second sponsored event that took place in 2017, again to raise money for brain tumour research. And we now are a named charity for the university sports teams, and so all the sports teams have brain tumour research on their t-shirts when they play sport. So this university has backed this topic maximally in a really very gratifying way. So I'm going to talk a little bit about drug delivery, and this slide summarizes, points out the website delivery consortium here, and if you're welcome to visit that, there's quite a lot of information, and we're trying to encourage researchers, regulators, the drug industry, strategic investors in research to say that if we want to solve the problem of brain tumours, we not only have to think about which drug might work, we also have to think about how do you get it to the tumour. And the bottom line is that the brain and the bloodstream are divided by something called the blood-brain barrier, which physiologically prevents drugs or molecules, large molecules, water-soluble molecules, from penetrating the brain. And this means that the drugs that are produced by the drug industry, unless they have characteristics designed to cut across the blood-brain barrier, don't get into the brain, and probably don't get into the brain tumours as a result. And so our strategy is to say, yes, we need new drugs. Yes, they need to be targeted against molecular steps in the cancer development pathway. But more importantly, they need, in addition, to be got into the tumour with a specific mechanism. And so that's what I'm really going to talk about today. And we identified this as a priority in thinking about the different approaches to enhance. I'm not quite sure why that keeps coming and going. And so we talk about biotargets, and there's an enormous amount of work has been done looking at biotargets. And we know a lot about the molecular environment of the tumour now. And there are many drugs that are candidates for tackling those targets. But at the moment, most of the drugs that come out of the drug industry do not penetrate the blood-brain barrier. And so our hope of finding a target and a drug may be compromised by this fact that they cannot pass through the blood-brain barrier. We're also interested in brain injury, and some of the people will be talking about later in the day. So, drug delivery is our theme, and there are different ways of doing this. And this is an example. One of our researchers developed this cartoon, and it shows the idea that you have a cavity in the tumour, and you may put a bioadhesive gel into the cavity which contains drug, which then delivers the drug to the cavity. That's a simple concept of drug delivery, but how you make that safe in clinical practice is complex, and there are people in the room who can talk about that later. So today, what I want to do is introduce the concept of drug delivery. I started that. Think a little bit about the blood-brain barrier. We've mentioned that. Want to think about reasons for drug resistance. So why do some tumours not respond to drugs, and why do others? So that's one thing. And then talk a little bit about drug delivery systems that are in development, and I'll show you a couple of examples. And then at the end, I hope to show you something from the patient's perspective. Everybody talks about brain tumours, but actually the pathology have just reissued their classification, and there are over 110 different types of brain tumour as identified under the microscope. So that's actually quite bewildering, because if you get very precise, that means you have 110 different unique targets in one, and that's with just one target per tumour. But each, when you come to study these tumours, there are often 5 or 10 targets that are potential. And so you have a very large number of biological targets potentially when you talk about brain tumour. In childhood, there are a subgroup which present predominantly in young people, and I'm going to very briefly tell you which they are, because it helps you understand that no one problem, there's not a single problem here. So the top left here is a piloaesthetic astrocytoma. This is a benign brain tumour, and the surgeons are very good at removing this, and they almost never need any further therapy, and 90% of them are cured. The problem is, and these marks mean this, that they can have ataxia, unsteadiness afterwards, because the cerebellum is a coordination centre. And also they can, if they've had bad delay in diagnosis, they often lose vision, so they can have impaired vision. This one here is a hypothalamic astrocytoma, which is a tumour in the middle of the brain, and the hypothalamus that controls your appetite and endocrine system. And they often present in very early childhood, in the first 2 years of life, and they have funny eye movements, and they often don't grow properly, and so they have problems with nutrition, because their metabolism's working too fast, and you can't give them enough food to fill them up. And so when we treat those, about half of them respond to chemotherapy, but half of them don't. And so they sometimes do die, sometimes they respond very nicely. So they're a potential target for drug delivery, because not all of them respond to therapy. There are new drugs coming along which may be suitable, but they suffer from blindness and endocrine problems after they're treated. This is a group of tumours linked to a condition called neurofibromatosis type 1. And that's a genetic disposition syndrome, and can present tumours in the optic and present blindness. And in fact, the treatment there is not to save their life, but to save their vision. So blindness is a problem, and they also have endocrine problems. And so, yeah, try that. So they are probably not suitable for drug delivery, although we are getting a whole new bunch of drugs to test these, and we're assuming, we don't know, that the drugs will cross the blood-brain barrier. They're about to launch a trial, but they don't know for sure that they cross the blood-brain barrier. Brainstem glioma, this is a low-grade brainstem. There's a tumour here right at the top of the brainstem, and that's where all the main nerves from the brain go down to the rest of the body here. This is a low-grade tumour, and Stuart, who's our neurosurgeon, if I asked him to operate on that, he'd say, no, thank you very much, I would likely to paralyze the patient. So he can't take the tumour out. So what can we do? Well, we can treat these with drugs, and we can treat them with radiotherapy. It's very central placed, and they sometimes respond to drugs, but they don't always. Normally they respond to radiotherapy, but the risk is that they end up with paralysis from here downwards, because of where it is. Similarly here with a spinal astrocytoma, if I ask Stuart to operate on that, or one of his colleagues, they'll say, oh yes, sometimes we can get these out very successfully, but sometimes there's no plane, and so we can't get them out. And then you have an option of either doing nothing, or giving some trial of drugs, or some radiotherapy. They can be problematic, and they can paralyze the patient. These two groups of tumours are medulloblastoma, and Beth's going to talk about those. They're malignant brain tumours. They occur in the back of the head and the cerebellum. They can spread down the spinal cord and around the brain. And if they present under the age of 5 or 3, the brain's still growing and developing, and so it means if we use radiotherapy, we'll damage their memory and their growth very severely, and we tend not to use it. And so they're a group of patients who, because they can spread, they're wondering whether we should deliver drugs to the spinal fluid directly as a way of drug delivery, because that may be a better way of treating them and giving very big doses of chemotherapy or radiotherapy. And if they happen over the age of 5 or 3 or 5, then we can use radiotherapy, and something like 80% of them are cured as long as they don't have metastases. This is a patient's tumour that happens in adolescence, and particularly it's called a germ cell tumour. And they present with hormone problems, so they often have abnormal puberty. And they may be blind when they're presented because they get hydrocephalus, and they can spread down the spine. They're actually very sensitive to chemotherapy and radiotherapy, and 90% of them are cured. And they may be a group of tumours where if we deliver drugs to the spinal fluid that could save us irradiating the whole of their spine, but it hasn't happened yet, but it's something we're thinking about. This is a tumour that our centre is particularly interested in, ependymoma. They occur in the back of the head, mainly in children, and they can occur in other parts of the brain in adults. And they're very large often when they present like this done. And the surgeon has really got most of the responsibility for curing these. If they can get them all out, then there's a chance of being cured. If they can't get them all out, then generally they keep coming back, and drugs are almost universally ineffective at the moment. And it may be that delivering drugs directly to the tumour maybe is an area that we haven't explored yet, or delivering, and Stuart might talk about this, electric fields in that area may be a futuristic way of approaching these. And so we're really interested to know why they're resistant to chemotherapy, and it's not clear. So that's still work that's undergoing. This is the signature tumour that we worry about drug delivery, and I'll tell you a little bit more about that. That's what they call a diffuse pontine glioma. And some of you in this room may know children or have had children who've had this, and it's a very distressing condition. It's the one, when we meet somebody whose child's got this, the current evidence says that 90% of the children are dead in 2 years, and there's no effective therapy apart from radiotherapy, which is temporarily effective, and then the tumour regrows. And it is an area, these are high-grade gliomas. They have now got a new molecular signature that tells us that they come from a certain developmental pathway in the brainstem that makes them attractive, and maybe new targeted drugs will come forward. But this part of the brain, the blood-brain barrier, is particularly tight. And so we give the drugs into the bloodstream, they probably won't get in. And so this is an area I'll talk about later, where we're using a technique convection-enhanced drug delivery, where we're actually injecting drugs directly into the tumour to try and bypass the blood-brain barrier, and I'll show you evidence of that. And then this one here is a atypical rhabdoid tumour. And these occur in very young children. They're very aggressive, very fast-growing. And you have to use very intensive chemotherapy with both into the bloodstream and into the spinal fluid to try and control them. And we are making some progress. There is some improvement. And we also understand the biology of this disease. And there is a possibility. But drug delivery is already part of these treatment programs with intra-CSF therapy. And there may well be other treatments in the future. So that's a whistle-stop tour of the whole of neuro-oncology in about 5 minutes. That's taken 30 years to get to that point that I can do that and not be challenged by everybody saying I'm not talking about it, not sure what I'm talking about. This is a word map that I asked an experienced audience in London to produce at a conference, and asked them what they meant by what meant to them precision medicine. And you can see that the biggest word was targeted. And I think in the minds of the people there, they were thinking of biologically targeted, actually finding the marker and the drug combination. But actually, in brain tumours, I think targeting the drug to the tumour is another really important part of precision medicine, and that's what the Drug Delivery Consortium is seeking to enhance in people's minds, is that we don't think about how we get it to the tumour, we may not get our drugs to work. So we developed a concept here with our collaborators of hatch, match, dispatch, and deliver. It's a kind of racy title, is how do you get a drug to market? And you had to hatch an idea, so you had to think about the biology of the drug, of the tumour, and you think about drugs that might tackle that biology, and you might say, well, that's the first thing. And then you had to think about how you might combine these with a drug delivery system. So that was matching them. And then you'd have to do some research to prepare them for clinical practice. So that's doing some early research in the laboratory to say this drug works, this delivery system works, it's safe to think about putting it into patients. And then you have to deliver it in a clinical trial. And we're going to show you 2 examples of where we've tried to do this. Hatch, match, dispatch, and deliver. And this is the first one. I'm working at the moment with a group in Bristol. Seems to have a life of its own, this thing. A guy called Steve Gill. He's a professor of neurosurgery in Bristol, and we're working with, several of us are working with his team. And he has developed a number of pieces of technology working with a company called Renishaw. And the first piece of technology is this catheter. This is a micro catheter, can be put into the brain. And the unique thing is it's got a little sleeve on the outside that prevents reflux of the drug up the track that the catheter goes through the brain. And this delivers a globular convection-enhanced drug distribution around the tip of the catheter, rather than it refluxing up the catheter side and just coming out the surface of the brain, because that's what happens if you don't have that cuff. The second thing he developed was a bone-anchored device through which he could anchor these catheters when he placed them into the tumor directly with a robot, driving the catheter into the precise location that he wanted to put the catheter tip. He can then connect them all up to a single catheter, which he then brings out on the surface of the skull with a syringe hub here. And that's a picture of the child syringe hub, to which we can attach an infusion device so we can infuse drugs directly into the brain. And this is a video I'm going to show in a minute of that happening to that little boy. These are 2 videos here. So you just click. Yeah, go back. No, sorry. Click on that one. Yeah. So this shows you, if you can see it, this is a movie MRI scan showing the tumor in red in the middle and the 4 catheters going directly into the tumor. 2 from the front of the skull and 2 from the back, so that the catheters go directly into the tumor. Just press that again, just let people see it again. Keep it moving. And then if you go over to the one in the bottom left and run that one, it should be a video. And this is a silent video. There's the catheter externalized, and this is the process for connecting it. And what's really interesting about this is it doesn't hurt, which for children is really important. And this is the operator linking up the infusion. We can run 4 infusions at once into the catheter at different rates if we choose. And the aim is to encompass the whole tumor in drug infusate, so that the drug is actually soaking the tumor bed in its entirety. And he's connected, use a bit of Meccano, you have to use a screwdriver. You connect the circular device onto the hub. You then screw it tight to make it tight, and that's what he's now winding the needles into the hub, which connect up with those 4 catheters I showed you on the device, so that we know which syringe is delivering to which catheter, and we have a catheter map knowing exactly where the drug's going. And then this is the boy having his infusion. The infusions go on for about 12 to 16 hours, and they have play therapy, they watch telly, they do their homework, they talk to their friends and family on Skype. They're perfectly well. They can have fluctuations in their neurology, so we have a scoring system that measures how well their brain's working, and the nurses apply that on an hourly basis during the infusions. And we occasionally see some of the nerves functioning less well. We slow the infusion up, and that allows it to recover, and then we restart the infusion. So that's a way of delivering drug directly to the tumor. It's happening now, and we hope to launch the trial in next year for patients to be recruited to give drugs into that route. And the drugs we've chosen to use are carboplatin, which is a chemotherapy agent that we've all used for many years, which if you're given doses sufficient to penetrate the brain causes severe bone marrow toxicity. But in the quantities we use here, it has no effect on the bone marrow whatsoever. The other drug we're combining with is sodium valproate, which is an anti-epileptic drug, which also attacks the HDAC molecular mechanism in the cell and arrests tumor progression with that. And the 2 things work synergistically. And so we're combining these two drugs to try and see if that will produce a better response. We have seen responses in patients treated on compassionate use, and we have seen people live much longer than we predicted as a consequence. And the reason that this is a particularly important model is that a tumor of the brainstem is in the part of the brain that keeps us all breathing and our heart rate going. And so if the tumor progresses there and causes damage, then we tend to die from breathing problems and heart rate problems. So if we can control the tumor in the brainstem, we would expect to keep the patients alive longer, which would give for us longer to think about other ways of treating the rest of the problem of this tumor, because they do spread beyond the brainstem. And so we need to think about how we're tackling that. But we have to get step one right, to show it's safe to do this in the brainstem with this drug combination. So that trial has currently been, has been moved to beyond the first stage of approval with the national groups. The European Medicines Agency have approved it, so we put it for ethics approval at the end of this month, and hopefully open it in March of this year in London. All the patients will be treated at Harley Street Children's Hospital, free of charge. There'll be no charge. The hospital's bearing the cost of that, and we're seeking other funds. So that will be done in that particular hospital environment that's been designed to accommodate that needs for anybody, and it will be an international trial, so people can come from outside the country, can also come from the UK. So to get to that point, the Bristol team had to do the preparation for dispatch, which is the molecular work to say that the tumor would be responsive to these drugs, that the drug combinations would work. They had to use animal testing, and some people may have sensitivities about that, but we can't do this sort of thing in humans without testing it in animals first. And so all that was done in order to get us to the point that we are at now. Next. And the challenges of this are summarized here. We're working in new ground. How do we know how much drug we're giving? Well, we know how much is in the syringe at the beginning and how much is in the end, but we don't know how well it's distributed. So finding ways of looking at the drug distribution using MRI is an area that we're looking at. The MRI is a fantastic technique, but how we actually measure the distribution of drug is really important. Measuring the response. These tumors fill up a structure, and they don't always shrink when they respond. They just don't progress. Sometimes they swell before they shrink, and so that is a problem in our assessing it. It's opening the door to repurposing drugs. I said at the beginning that the drug industry make drugs that are water soluble and not fat soluble, and that means that most of them don't get into the brain. This is a really good thing for this technique, because actually water soluble drugs don't get out of the brain. So if you put them directly into the brain, they don't get out very well. So it's opening the door to a load of drugs that were rejected, probably because they didn't get into the brain, and may well open it up for new use in this way. But it's a small number of patients, it's going to be slow progress, and it's got to be safe. We can't make the children worse with this. That's really important. And how do we do clinical trials? This is a new technique, there are new things, and it's been very challenging, and our colleagues have provided with loads of guidance, and we're now getting to the point where I think the trial is acceptable, but there was a long period of time where there was a lot of criticism, and I think we've addressed all of those criticisms. We are moving forward. Okay, move on. So, move on to the next one. Don't worry about that, we've seen that already. So the second area that we've particularly taken interest in is, and I mentioned it earlier on, is giving drugs into the spinal fluid. Now, the brain is floating in spinal fluid, and in leukemia therapy, we've been giving drugs into the spinal fluid for 30 years. And it's been shown to be a very effective way of preventing CNS recurrence in leukemia. But it hasn't been used extensively in brain tumours. And I'm not really sure why. There is a video which we haven't got time to watch now, but we can send that out to all the participants so you can see it later. But this is a diagram to show the places where we can give drugs into CF. We can either give it into the ventricular system in the brain, or we can give it into the lumbar root down here. And we preferentially give it up here because the CSF is made up here and flows down the spinal cord and is reabsorbed in the outside of the brain. But sometimes there's an obstruction up here due to the tumor, in which case we give it down here and then they travel up the other way. So we've got a way of dealing with anybody who has a brain tumor if we talk about intra-CSF therapy. Next slide. So we did some early work, and we looked at which drugs would be suitable for giving into the spinal fluid, because the spinal fluid is in direct contact with the brain. If you have a drug that's got very toxic properties, you don't want to give it directly into the brain. It can be devastating. And so we selected a drug called etoposide, which is well known to us as oncologists. And we gave a patient oral etoposide every day for 2 or 3 weeks. And we also gave the same patient CSF etoposide. And we saw response in the and around the CSF spaces, but progression in the tumor, which gave us confidence that the method of drug delivery was important for the effectiveness of this drug. Next slide, please. So if we direct drugs directly to the CNS, you can achieve cytotoxic tumor concentrations bypassing the blood-brain barrier, which saves a lot of drug and toxicity. But you need to match the effective drug, the biology, and the optimal delivery system. Next slide. So Michael Vluberg, who's a neurosurgeon, works in Nottingham, did a lot of work on understanding the flow of CSF around the brain and spine. And he made physical models, he made mathematical and computer models, and he studied the flow of CSF, because if you're going to inject drug, then you need to know where the drug is distributed. So we've developed an enhanced understanding of that using various engineering principles. We worked with a man who specialized in getting coal into power stations. He said CSF was just coal in smaller lumps. He was an engineer. Next on. Next slide. And I'm not going to go on to that now because we haven't got time. And just the next slide. So we've had some preliminary experience of using intra-CSF drug delivery in children with relapsed brain tumors. And this slide was taken from a poster presented in CEOP in Japan 2 weeks ago. So we've treated over 25 patients with intra-CSF etoposide as part of their palliative therapy for brain tumor after it's recurred. And there were 16 male and 13 female. The median age, half of them were younger than 4, the other half were older than 4. And the sorts of tumors we treated were medulloblastoma, ependymoma, pineoblastoma, lymphatic leukemia, can't read that, PNET, and a number of other ones. So it's a variety of patients. And we got this survival curve. Now, sadly, they all had relapsed disease, and so they were all at risk of dying. The red line here is the predicted median survival, and the yellow line is the actual median survival. So we think, first of all, we were able to treat them for an average of 325 days, which is nearly a year. And we think we prolonged their progression, their survival as a result of this. And if you watch the film when you have more time, you'll see the patient saying how tolerable this was and how it really allowed them to get on with their lives without having lots of disturbance, and nothing like as bad as it was to having systemic chemotherapy. And so we concluded from that we can give intraventricular etoposide. It's well tolerated. We had quite a lot of problem with infection of the device. 24% of them had to stop the treatment because the device got infected. And so this remains a problem. And Steve Gill, who designed the other system, we are thinking about whether we can make a device that might bypass the problem of infection with this idea of having something that comes through the skin. So we're thinking about that. Next slide. We designed a trial called Intrepid, and we got funding for the trial from CRUK to study intra-CSF drug therapy. And we're all ready to go, except for one problem, is we haven't got a reliable system for attaching a semi-permanent infusion to the device in a safe way. And we had thought we could run a catheter from the scalp under the skin and put a portacath here, which is the device we use for intravenous administration. But we were told from a governance point of view, we couldn't have one going to the venous system and one going to the brain, because there could be a risk of error of people giving the wrong drug via the wrong route. And so the trial is currently suspended until we find a solution to that practical problem. So progress in research as rushes forward and then meets blocks, and then you have to wait and sort something out and then rush forward. And I think we're prospect of creating a device that could be used which avoids the portacath solution is in our minds, but it's got to be created. And that would allow the trial to go ahead. Next slide. I think. So that will bring me to the end. So the idea of hatch, match, dispatch, and deliver, I've tried to talk to you about how you take practically a translational research journey from an idea through to an end. And I think we've got now one trial about to be launched. We have a second trial designed, but waiting for that last delivery element to come through. And then there are a whole raft of other things to do with drug delivery, which I'm not going to talk about, which could well be developing in parallel. So we feel that the opportunities going forward are quite good in this area for research and investment and for realization of benefits. Thank you very much.